Hello, everyone. Thanks for joining. So we'll be going through infectious keratitis today. So we're going to keep it quite focused, looking at specifically infections of the cornea, and how the sort of what the differences are between how they present and how to sort of think about what potential causes are. So we're going to just talk about an approach to microbial keratitis to begin with. So what your typical patient will present with, what to think about, what to consider when you're taking your history, and then how to treat. And then I'm going to spend some time just touching on four separate sort of causes, looking at acanthamoeba, fungal keratitis, and then specifically looking at herpes simplex, sorry, and varicella. I find that with keratitis, I mean, most people are actually, quite good at sort of starting the initial treatment, because, if somebody comes in with a stromal infiltrate, then, they'll be started on treatment for a microbial keratitis. But I think it's always worth having in the back of your mind, differentials as to what your microorganism could be, depending on what the presentation is. And there are certain clues that you can get from the history as well as the examination, that can help you think about potential, underlying causes, to the keratitis. It's all well and good starting somebody on the initial treatment, but it's useful sort of for your own practice to think about what could potentially be going on. So this is going to be your typical patient. Somebody comes in, they've got pain, potentially a bit of a vision drop, depending on where your ulcer is or whether or not they've got any edema of the cornea. And you're going to find this sort of stromal infiltrate. It will probably have an epithelial defect. The eye will be quite red. They're going to be in a lot of pain. You're potentially even going to have a bit of uveitis. And this is your sort of typical patient coming in with a microbial keratitis. It's going to have a relatively acute history. It'll be 2 or 3 days, not getting better, potentially even getting worse. And these patients are going to be incredibly uncomfortable. Corneal infections are not the nicest. And when you're approaching a patient like this, it's really important that you elicit a lot of things from the history. So the timing is quite important because when you're looking at certain microorganisms, things kind of develop a bit slower. So something like Acanthamoeba actually develops a bit slower than your kind of typical bacterial keratitis. And actually fungal keratitis can even be slower yet. So it's useful to know how long they've had their symptoms for and what symptoms came first. Was it a vision problem first before it was pain? Was it pain before vision? And their pain, get them to describe it. Is it quite a null, gnawing pain? Are they photophobic? How is their vision? And actually, sometimes, obviously, from a clinical examination, you can tell whether or not someone's vision is going to be poor, but it's useful to know what their vision is like. And whether or not they have any discharge, is it purulent, sorry, and what sort of discharge it is. And then the risk factors are really useful. Is this a patient who's had any recent trauma to the eye? And actually, even if it's not recent and it's very, very old, these are patients who can still kind of are at risk of developing a microbial keratitis. So somebody, for example, who's had a previous foreign body with an organic matter may end up with recurrent corneal erosion syndrome, and then they just get infected, and one thing can lead to another. Contact lens wear is an essential thing to elicit from your patients, and the kind of contact lenses they're wearing and what their lens hygiene is like. So it's useful to know whether or not they're wearing dailies, which usually come with the lowest risk, or are they wearing monthlies? Well, how are they cleaning their contact lenses? How long are their contact lenses being worn for? Are they swimming in them? Are they showering them? I've I've unfortunately had patients who come in and they're telling me, they've been swimming in open water and in lots of, lovely different places around the world, and then they come in with a raging microbial keratitis. And so it is really important to elicit that contact lens history and whether or not their contact lens hygiene is potentially putting them at risk. Do they have ocular surface disease? Anybody with an unhealthy ocular surface or an irritated ocular surface is more at risk of these things. Do they have any lid malpositions? Any entropions, especially trichiasis, patients with lagophthalmos, with exposed corneas? These are patients who are more likely to get risk factors, or more likely, sorry, to be at risk of a keratitis. So there's also a video on my on the channel that kind of goes through lid malpositions if you wanna give that a look as well. And then there's also iatrogenic risk factors. So patients who've had previous surgery, especially loose sutures in place, can increase the risk of the patient developing a microbial keratitis. Are they immunosuppressed? Do they have, for example, a vitamin A deficiency? So there are lots of risk factors that you can elicit from the history. And then from your clinical assessment, you're going to see probably a red eye, there'll be a whitish opacity, there's probably going to be an epithelial defect, some anterior uveitis potentially. You're going to want to check they've not perforated, and the clues to that will be, for example, how how formed is your AC, your anterior chamber? What's your pressure? Can you see a leak? Is it Seedles positive? Do they have an endophthalmitis? How bad is their vision? Do they have a vitritis? Can you even get a fundal view? All of these things can really, you can start off with quite a simple microbial keratitis, and really very quickly it can develop into something much more dangerous to the patient. So do consider what could be going on in a patient, especially if their clinical presentation isn't really in line with what you're eliciting from the history. And then when it comes to investigating it, obviously you're going to want to do scrapes, especially if your ulcer is anything above a millimeter. You're going to want to use different mediums, and you can do your own reading to try and to learn what the different mediums are and what they're kind of useful for in terms of bacterial, fungal, or Acanthamoeba keratitis. And for your own exams, you can kind of just rote learn those essentially. But you're going to basically want some sort of blood or chocolate agar, and you might want a subarodes as well, and maybe some E. coli if you're thinking acanthamoeba. And you want to use a different needle for each sample. You kind of want to go from normal cornea into the ulcer, and you want to try and then spread it along your sample. Remember not to actually pierce your medium. You want to just sort of rest that sample on there. If you do have a contact lens there, if the patient has brought their contact lenses in, do consider sending those, because they can be a very useful thing to use. And if you're worried about any viral causes, or if you're thinking herpes simplex, consider taking a corneal PCR as well. And then in the later stages, or if for the riskier cases, you may want to consider confocal microscopy, which is, if you have that in place in your center, then something like that will help you kind of distinguish between acanthamoeba and other causes. And then, if really worse comes to worse, then you can also consider actually sending corneal biopsies as well. And the general management, you will have come across this. You're going to start them off with a broad spectrum antibiotic, and this is kind of most likely going to be something like a fluoroquinolone, so something like ofloxacin or moxifloxacin. And you're going to start them on really intense treatment to begin with. So these are patients who are going to get, especially if you're worried about a contact lens associated keratitis, these are patients who are going to get hourly drops day and night for at least 48 hours, and then potentially hourly drops during the day for the remainder of that week before coming down to a less frequent regime. You can then also consider kind of combined therapy. So there is some evidence to suggest that, obviously your fluoroquinolones don't really cover the gram negatives very well. So if you're worried about something like a Pseudomonas, you may want to consider adding something like a gentamicin. But just remember, aminoglycosides do need to be used with caution. They can be quite toxic to the ocular surface. So, get specialist advice before you're doing something like that. Give them some lubrication to help with their sort of general symptoms, but if they're putting a drop in every hour, they may not necessarily have the time to do something like lubrication. And then importantly, just don't forget to try and manage their pain. So give them their cycloplegics, try and make the eye more comfortable. And then you want to start worrying about whether or not there are complications. So is this a patient with a resistant keratitis? Have they come back after the treatment and the treatment isn't working? Step one is just reconsidering your diagnosis and whether or not you're treating the wrong bug. Otherwise, you might want to actually kind of step up on your treatment, give them some oral fluoroquinolones. They're the only things, well, fluoroquinolones at least have shown some, decent bioavailability in the cornea. You may want to consider giving them some oral tetracyclines, maybe some vitamin C, and that can help with these resistant cases. Endophthalmitis, obviously, you're going to want to take a vitreous sample. You probably want to take an anterior chamber sample as well if you can, and then give them their intravitreal antibiotics and go down the endophthalmitis route. There'll be protocols wherever you work as to how that's managed and what antibiotics are used as per sort of microbiological guidance. And then lastly, corneal perforation. And I wanted to sort of touch on this specifically because obviously it's useful in the acute setting to know how to manage it. And in later sessions, I do want to sort of go into a series on ocular emergencies and things that you'll find in accident and emergency and how to manage. But I wanted to touch on corneal perforation today. So you've got the kind of small perforations, less than about 2 millimeters, and then the larger ones. And for your small perforations, you can even just consider putting a bandage contact lens on. And I've seen that actually being done quite successfully. Or you may want to actually just put some corneal glue on to plug that hole. And then with the larger perforations, these are patients who may require amniotic membranes or potentially even tectonic grafts as an emergency, if they're essentially just, completely in a corneal melt or they've got too much of their cornea missing. And with corneal gluing, I wanted to show a bit of a video of a patient that I had seen myself and how we glued it. So what you can see here in this specific case, so as you raise the lid, you could see this dilution of that fluorescein. So you've got a very obvious CDOS positive patient here. This is a patient who had a previous graft and was leaking post-operatively. And this is someone you ideally really want to close. And with the corneal gluing, what you're going to do is depending on how you want to do it there, but I like to use a sterile drape and a hole punch, and then we use that corneal glue and you apply it exactly where that leak was, and then you essentially again just go back in with the fluorescein and check that you've blocked your leak. Um, I may want to try and actually make a video in a future session to kind of show how I do corneal gluing. There's lots of different ways to do it. I find the nicest way is actually not to use the corneal glue minim that it comes in to actually apply the glue. I think it's far too big and you end up getting too much glue on the drape. So what I actually do is I empty the corneal glue into an insulin syringe. Um, and then I use the insulin syringe to actually then inject the glue onto the drape because actually I find with that needle in place you have a much more controlled amount of glue going onto your drape. So then when you actually apply it to the eye, you're not getting too much glue. It's not a mess, and it works really nicely. But in your own centers and in your own training, you will kind of come across the different ways that your corneal colleagues will have done corneal gluing, and they're the best people to sort of to learn from. So then for the sort of second half of the session, I wanted to kind of go through these specific microorganisms and what in your history, what in your investigation is going to be different, and then how are you going to treat it a bit differently. So with Acanthamoeba, this is a picture of somebody who's actually got chronic Acanthamoeba. And in the acute settings, patients with Acanthamoeba keratitis, these are patients who are going to be immensely painful. And actually, sometimes that pain is completely out of proportion to what you can see clinically, especially in the early stages. You might see some perineural infiltrates. These are quite difficult to actually see on an examination, but these are pathognomonic for Acanthamoeba. So if you see those, you are looking at Acanthamoeba. You will see some pseudodendrites, some stromal ring infiltrates, for example, and that ring infiltrate doesn't necessarily happen very quickly. It actually takes some time for it to fully develop. You start with these stromal infiltrates first, and then they slowly collect into a ring. But that doesn't necessarily happen in the acute setting. You get that very, very painful episode first, and then that will slowly then develop into the clinical picture that you see. The important note with the pseudodendrites is that any patient that you see with a contact lens and has a dendrite on the eye, or something that looks like a dendrite, don't immediately go down the herpes simplex route because a lot of these patients with acanthamoeba have actually previously been erroneously treated as a herpes simplex, and only when they come in for their second review do you realize that's not even touching the infection. So if you see a pseudodendrite, especially in a patient with a contact lens, definitely think acanthamoeba and be worried about that. I've actually just realized I've spelled acanthamoeba wrong. Um, then the specific treatment for acanthamoeba, again, it depends on where you work, but what I've seen mainly being used is something like PHMB, and that's essentially a biguanide, and that's a very useful treatment. There are other things that you can use for anti-anemic agents, so things like aminoglycosides. There's like imidazoles that you can use, and they all work a bit differently. But PHMB is an excellent way of treating acanthamoeba, and these are patients who are going to be on treatment for a long, long time. It's really quite prolonged. These are patients who are going to expect to be on treatment from anywhere between 20 to 40 weeks even. So these are patients who are going to be in a corneal clinic for a long, long time, and then they're going to eventually scar. And these are patients who will eventually be treated with something like a PK if it's necessary. But you really want to make sure that the cornea that you're dealing with before you go into a graft is completely sterile. So they're going to have very, very prolonged treatment because the risk is if there's any acanthamoeba there that has not been completely treated or eradicated from the cornea and it's not sterile, as soon as you put that graft in, that graft's going to get infected as well. Um, so there's ongoing treatment after the acute treatment, and there's also lots of different complications that you can think about with acanthamoeba. So these are patients who potentially have scleritis, which usually is associated with a poorer prognosis. There's going to be sort of severe corneal scarring, and I've spoken about those PK considerations, extensive necrosis sometimes, and actually sometimes these patients are in such intractable pain that actually some patients are eventually treated with enucleation because of how bad that pain is. Because remember that pain will even be coming from the sclera itself. So an evisceration itself may not be enough really to treat that painful eye a bit differently to how you would treat, for example, a painful blind eye in glaucoma, where the pain is coming from the pressure. So an evisceration may be all you need. But with something like an acanthamoeba giving you that severe intractable pain, a lot of it is coming from a chronic untreatable scleritis. So sometimes, in very rare cases, the entire eye needs to come out. And importantly, with the Acanthamoeba is what you'll almost certainly elicit from the history is very, very poor contact lens hygiene, for example. So it's really important that you educate your patients, especially if they're patients who are going to be on extended contact lens wear. So these are patients who are going to be, rinsing their contact lenses in water, in tap water. They're going to be swimming in them. They'll be out in ponds. So all of these risk factors are almost certainly going to be elicited from a patient in front of you who has Acanthamoeba. And we've spoken about those samples as well. So you're looking at things like the non-nutrient agar with E. coli. You're sending things depending on what you've got in your department as to what you can send, or you're going to do some confocal microscopy in vivo as well, where you can see these cysts, which is diagnostic of Acanthamoeba. And then talking about fungal keratitis. So fungal keratitis is something that you're going to see very rarely. There tends to be certain risk factors. So patients on immunosuppression, for example, long-term topical steroids, patients who've had trauma, and specifically trauma where they've had the eye being contaminated with organic matter, things like leaves, tree branches, for example. And while fungal keratitis is a bit of it's a tricky one because it can present very slowly, but it can also present very rapidly. So there's not a lot of rules that I think apply for a fungal keratitis, but this is purely from my own experience as a registrar. So there's two sort of main types. You've got your yeast fungi and your filamentary fungi. The yeast fungi tend to have this, in the textbooks you're going to read about like a sort of button appearance, whereas your filamentary will have this sort of feathery branching, potentially some satellite lesions, which is the picture that I've shown here on the right. And fungal keratitis is going to have their specific treatments. So while these patients will probably have been put on a empiric treatment with antibiotics, if you're thinking fungal, you're also going to give them some topical antifungals. And which topical antifungal you give will be really dependent on what you have and what your guidelines are. So, you can give lots of things like amphotericin, natamycin, any of the zoles, for example. You've got clotrimazole, for example, voriconazole. So there's lots of different things that you can give for the antifungals, and it tends to be that amphotericin and natamycin work a bit better, and then your oral voriconazole or oral antifungals can be given for patients with either very severe disease or patients who are under immunosuppression, for example. And these are patients, while you'll consider giving them oral treatment, you still want to make sure that you're continuing on with their topical treatment. And again, the treatment of fungal keratitis is a lot longer than what you would find with bacterial keratitis. You can treat a pretty simple bacterial keratitis with 2 weeks of antibiotics, whereas with a fungal keratitis, you're looking at, 12 up to 20 weeks of treatment that these patients are going to be on to ensure that they're completely sterilized their cornea. So, these are patients that are going to be treated in the initial stages very similarly. You're going to take your scrapes, you're going to send things off on your appropriate plates, for example. And then you're going to, if you're considering this fungal treatment, you'll then kind of give them those antifungals as a measure to try and treat what you're looking at. Then you're going to see a fair bit of this over the course of your training. And herpes simplex keratitis is a mammoth topic, and I'm really only touching on it today. And the thing is with herpes simplex is that one of the things I remember one of the cornea bosses I worked with basically said is that if you see essentially any sign on the cornea, one of the things that you can hedge your bets on being a potential cause is herpes simplex. And that's because it has really a wide range of potential problems that it can cause along the cornea across all of its layers. So starting with the epithelium, usually a herpes simplex keratitis actually starts off not looking that dissimilar to a severe dry eye or an adenoviral keratitis. So you'll get these sort of punctate, superficial punctate keratitis, and they sort of slowly develop into dendritic ulcers. Now, the thing is with dendritic ulcers is the thing to remember is that a dendrite is pathognomonic of herpes simplex. Nothing else causes a true dendritic ulcer. Everything else is a pseudodendrite. So things like varicella, for example, things like acanthamoeba, even a healing corneal abrasion can cause them. Those are all pseudodendrites. And the thing is that it's actually very difficult clinically to necessarily tell the difference between a true dendrite and a pseudodendrite. But in the textbooks, for example, if you're looking at a dendritic ulcer, that is herpes simplex. Everything else causes what we call a pseudodendrite. And with epithelial herpes simplex, with no stromal or no endothelial signs, they're going to be treated with topical acyclovir. So you're going to give them something like a ganciclovir gel. So depending on where you work, sometimes it might be topical acyclovir or ganciclovir, and then you'll give them something like a Vergan 5 times a day for up to 10 days. Now, with stromal simplex keratitis, again, this is plus or minus the epithelial. And as you go deeper into the tissues, into the cornea, usually it is coming with signs of the more superficial layers, but sometimes it is just those deeper layers that are being affected. So with stromal herpes simplex, you're looking at stromal opacities, scarring, and these are patients who, if they do have an epithelial defect, you're going to give them those topical acyclovirs as well. And these are patients that will benefit from systemic acyclovir as well. You can go and look at the exact details of the head studies, but essentially what that suggested is oral acyclovir is not very useful for epithelial. Herpes simplex keratitis, but sometimes it is used, especially in cases that are very recurrent, to try and prevent those recurrences. But in stromal keratitis, it does show some benefit. And then you can also then consider using something like topical steroids to try and reduce the scarring, reduce the inflammation. But you really want to try and make sure that those epithelial defects have completely healed before you then start using those steroids. And then with endothelial keratitis, again, as above, you may find those in the more superficial layers, but in the deepest layer of the cornea, when you're worried about an endothelialitis, the clues towards that will be a corneal edema because your endothelium isn't working. You may have some Deschamets folds secondary to that. You may see some KPs because, again, you may have an anterior segment inflammation. So you're going to see these KPs along the endothelium and potentially even some anterior chamber activity. And again, you're going to give them the topical acyclovir, you're going to give them the systemic acyclovirs, and these are patients that would definitely benefit from steroids, but again, you're delaying that until those epithelial defects have healed. So typically, when you're seeing a patient that you're worried that has a herpes simplex, what you're probably going to do is send off a corneal PCR, start them on topical treatment with acyclovir. You may want to give them oral acyclovir as well if you're looking at stromal or endothelial involvement. And then these are patients that are going to come back probably 5 days later once you have the results of your corneal PCR. And if at that point your epithelial defects are healing, you can then start to consider starting them on something like steroids, which will really kind of speed up the cornea clearing from an edema point of view, and help to reduce that scarring, which is where their vision may improve. But you really want to make sure that those epithelial defects have definitely healed. And obviously, with herpes simplex, there's lots of different complications that can happen. These are patients that can end up with a desensitized cornea, neurotrophic ulcers. These are patients that can also perforate, for example. Um, so, these are patients where you're going to also kind of consider all your different management. So, for example, the immediate corneal perforations with either gluing or potentially even tectonic plates if it's necessary. And the other thing to bear in mind is that with endothelial herpes simplex, if you are purely seeing um, some corneal edema, Deschamets folds, some uveitis, for example, and potentially even a high pressure, because these are patients that may even have a trabeculitis. These are potentially not necessarily just herpes simplex. You may want to consider doing an AC tap because things like CMV can cause it. You may be looking at something like a Posner-Schlossman. And again, I've done a previous session looking at those sort of anterior uveitis syndromes. So do consider your differentials when you're looking at these patients, especially if you don't have any epithelial or stromal evidence of herpes simplex. Consider whether or not you're looking at a herpes simplex sort of related uveitic or hypertensive uveitis, or potentially even something like a CMV. Um, and with those sort of patients, if you are looking at a uveitic or a hypertensive uveitis, that initial sample is really helpful because once you start these patients on treatment, if they're started on Dex or if they're started on acyclovir, that the that will kind of strongly increase the likelihood of getting a false negative from your PCR. So do try to make sure that you are considering whether or not you want to send off an AC tap when you're seeing these patients in the acute setting, because it can really help with your potential diagnosis further down the line. Yeah. So then, lastly, what I wanted to touch on was varicella. And so with varicella, it's sort of, in terms of corneal findings, that can sometimes be quite similar to your herpes simplex, and differentiating between the two, history is really helpful. Is this a patient who's coming in with herpes zoster ophthalmicus in the in the context of having shingles, for example? Do they have a fascicular rash around that V1 distribution? Hutchinson sign is where you're getting that fascicular rash on the tip of the nose, and essentially what that suggests is that they're essentially more at risk of then developing HZO, and that pain of that rash can really persist even after the rash is healed. So these are patients that would benefit from a physician involvement with things like neuralgic pain relief. And when it's just the shingles, if the eye is white and they have no ocular symptoms, just treat it as shingles. So just give them their acyclovir, 800 milligrams 5 times a day for the week. And these patients are not going to need ocular treatment unless they're coming in either symptomatic or they've got the clinical signs that you're worried about. And the things with varicella zoster is it can affect almost anything in the eye, and it's always very helpful when considering what the potential complications of having a varicella zoster infection are. Is just you think of the eye front to back, and if you're in the context of an exam or even just clinically, you are considering that all of these things can happen. So in the context of an HZO, you are looking at mainly corneal findings. So because of that V1 distribution and that sensation of the nerve coming up through to your cornea, you're going to potentially see, very similar to herpes simplex, that superficial punctate keratitis, potentially some pseudodendrites that's shown in that picture on the right with a patient that I saw some time ago. They may have some stromal deposits with like a nummular keratitis, again, an endothelialitis with Deschamets folds and AC activity. So it can look very similar to herpes simplex. But then importantly, what you can remember is that varicella zoster can also affect many other parts of the eye. So it can give you a hypertensive uveitis, usually in the context of those corneal findings as well. But importantly, the posterior segment infections can also be caused by varicella zoster. Now, I did some reading, and I think having somebody coming in with shingles and anterior segment findings and at the same time having posterior segment findings is exquisitely rare. We're sort of talking about, you might be able to find, fewer than 10 case reports online is what I could find of patients who had come in with a shingles plus a posterior segment finding, like an ARN, for example. But it is just important to remember that if you're thinking about shingles and this is a patient who already has evidence of a zoster infection of the eye, do look at the back and try and get a view of the back, because varicella zoster can definitely cause some problems at the back. So you can either get an acute retinal necrosis, an incredibly painful eye, a severe drop in vision, or you can get this sort of progressive outer retinal necrosis. And we'll talk about these in a bit more detail when I talk about your sort of posterior uveitis and your posterior retinitis. But it can also cause neurological problems. So it can give you an optic neuritis, it can give you nerve palsies and even stroke. So there's lots of things that varicella can cause, and do think of it sort of, working front to back, starting with your eyelids with that vesicular rash all the way back to the optic nerve, and the motility nerves as well. So that sort of brings us to the end of talking about infectious keratitis. It's a bit of a whistle-stop tour. And what I wanted to touch on was just, you're going to start off with empiric initial treatment. You're going to start these patients on a broad spectrum antibiotic. If you're worried that it's something that the broad spectrum is not going to cover, you may want to consider combined therapy. But there are some clues on the cornea, especially in those initial stages before they've started treatment, that can help to differentiate your microorganisms. Are you seeing something that looks like an Acanthamoeba? Does it look a bit more fungal in nature? And then what's the history of the patient? How long have they had their symptoms? What's their contact lens hygiene like? Have they been traveling anywhere recently? Any recent trauma? And all of that can help you decide whether or not this is a patient who's potentially an atypical microbial keratitis, or is it something bacterial that will clear with a couple of weeks of moxifloxacin. So it is very important to just take that time at the start to look at the cornea closely, ask the patient those pertinent questions, because you may miss those signs later down the line. And this is somebody who potentially has time wasted by being put onto the wrong treatment at the start or by missing out on important treatment that could potentially really change the course of their ocular health. We're talking about someone who potentially can have a cleared infection, a sterile cornea, and a very successful graft versus somebody who ends up with severe scarring, chronic infections, and even potentially eviscerations and enucleations because it just wasn't managed properly at the start. So do try and take that time at the beginning to really kind of consider what your likelihood of looking at an atypical microbial keratitis is. And that's why considering those risk factors is really important. And these are patients who you're typically going to just start wide with the treatment, look at your broad spectrum treatment, and then you'll narrow it down as your investigations come back. When you get your corneal scrapes back, when you get your PCR back, if you've done a confocal, when you look at that, you'll then start to narrow your treatment down. And what's important to remember when you're sending off those scrapes is it's really often that you're going to get false positives, or you'll potentially just get contamination. So you may be dealing with multiple different bugs. And it's quite likely that you can have a bacterial that starts off with an epithelial defect, and this is somebody who was mismanaged somewhere else to begin with, and then decides to get a superimposed fungal infection as well. So there are patients that have multiple microorganisms that need multiple different types of treatment. So don't underestimate what microbial keratitis can really become if mismanaged at the start, which is why what we said with, those dendritic ulcers, if you're seeing something like that on a contact lens wearer, consider what you're looking at as a pseudodendrite. It may not be herpes simplex. You may be looking at acanthamoeba. And if you leave acanthamoeba untreated for too long, that can really turn into a nightmare for both primarily the patient and also you as the clinician. So really do take your time, look at those patients, ask the pertinent questions, and really focus on what the cornea looks like. So that brings us to the end. I'd really appreciate your feedback again. There's a link in the description if you're watching this online. Thank you for joining. In the future sessions for cornea, we'll start to look at, different sort of inflammatory conditions of the ocular surface, looking at different degenerations that you may come across, and as well as looking at external disease in general. So please, 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 just as you're watching this, fill out the feedback. It just takes 2 minutes, and it really does help me. And these sessions are always going to be free. They're always going to be completely available, but the feedback really does help me. So thank you very much for filling that out. And we'll see you at the next one.